All right, welcome. So this session is about the Diagnostic Odyssey and newborn screening. So I'm Pat Furlong. I'm from Parent Project Muscular Dystrophy. We're a 30-year-old organization that focuses in on Duchenne muscular dystrophy. You've just heard about Duchenne and its recent gene therapy diagnosis, or gene therapy treatment. My two boys were diagnosed with Duchenne muscular dystrophy. I was in a medical career. My husband is a physician, and the diagnosis of my son took us 4 years. We had a little boy who didn't keep up with his peers, who couldn't do stairs and couldn't jump. But because my husband played football for Notre Dame, they said that they would grow into those very large muscles and they would be just fine. Along the way, I had a second son who couldn't do stairs. And after 4 years, my second son was diagnosed with Duchenne by an orthopedic surgeon who told us that there was nothing more to do, and perhaps if I knew I was a carrier, I could have aborted both babies. So the Diagnostic Odyssey is a long one and a painful one, but I think you heard Pam Gavin say this morning that receiving a diagnosis was a good day. It was a painful day, but a good day, because all of the things we worried about, all of the things we were asking about became a word: Duchenne muscular dystrophy. So I'm a very big fan of newborn screening. We have a package before the RUSP with a potential consideration and decision in May. So I'm very hopeful, and I think newborn screening for all of us in those painful days appreciated diagnosis. So I'm going to ask each of the panel members to introduce themselves. We have an amazing panel here. Dr. Tierney, Dr. Chen, and Dr. Irons will introduce themselves, and then we'll get into the discussion. Dr. Tierney?
Good morning, everyone. My name is Dylan Tierney. I am an infectious disease doctor, and I serve as the chair of the Massachusetts Rare Disease Advisory Council. I'm also the associate medical director in the Department of Public Health. And I'm very happy to be here. This topic is critical. As the Massachusetts Rare Disease Advisory Council, which I'll call the RDAC, began our work in September of 2021, we had some listening sessions from people with rare disease or caregivers of people with rare disease. And one of the first things that came up was the Diagnostic Odyssey, so as a main concern. So I think this is very timely, and I'm happy to have this conversation.
Thank you. Dr. Chen?
Thank you, and my name is Sing Cheng. I'm the head of research and product development at Alexion, which is the rare disease unit of AstraZeneca. My responsibilities are primarily to develop a pipeline of programs that are potential therapeutic solutions for patients with rare diseases. And part of that remit requires the development of methodologies that allow us to develop diagnostics and potentially access to these medicines that we're working on. I've been working in this space for multiple years and have had the opportunity and privilege to have worked on a couple of programs and contributed to the success and introduction of some of these medicines into past regulatory approval.
Dr. Irons?
Hi there, I'm Mira Irons. I'm a medical geneticist and a pediatrician. I'm currently the Associate Chief of Genetics and Genomics at Boston Children's Hospital, and I'm also the Program Director for all the medical genetics residencies and combined training programs. This is a topic that is dear to my heart and to all geneticists. I don't mind telling you my age, but I've been practicing medical genetics for 40 years. And during that time, actually, I was either the first, intermediate, or final step on a diagnostic odyssey for children with unknown conditions. And, you know, one of the things that often comes up is, what is a rare disease? And the answer to that from a geneticist perspective is, you know, there are 6,000 conditions that physicians like me have characterized clinically by their physical findings, by their developmental findings, and they are individually rare, but they actually make up a significant proportion of childhood disease, and about 1 in 12 children have those conditions. What has changed over time, and the reason I was either the first, the middle, or the last step, is our diagnostic testing has improved, and I think we're going to talk a lot about that now, because the ability to cut the diagnostic odyssey shorter and to really send children and adults to the appropriate provider has gotten much better.
So can you start there? Where were we and where are we now?
So I can tell you that, and I'm going to do this really quickly. When I started my training in genetics in 1983, we didn't have a lot of sophisticated testing. We had chromosome testing, so we can identify changes in chromosome number and missing pieces, extra pieces, and we had metabolic testing, amino acids and organic acids. And that maybe identified 3, 4, 5% of the kids we saw. We didn't send those kids away. We continued to follow them, and we were kind of the lifeline for their families. And the mantra was always, one of these days we're going to have a test that can identify your underlying genetic defect. And once we have that test, we can develop therapy, and we can go from there. In the meantime, we continued to follow the clinical manifestations. So we went from chromosomes and amino and organic acid testing to FISH analysis, to microdeletions, to chromosome microarrays. And over the last 5 to 10 years, we've finally gotten to a test, and it's exome analysis. That will identify an underlying defect in about 40 to 50%. Still not 100, but it's actually enough that can tell parents and children and families sort of what the appropriate specialty is, and it's opened the door for the development of therapies.
Thank you.
So, Pat, from my perspective, I think we've heard this morning there's still a very high level inequity in the rare disease community, and we've heard about the difficulty of access to critical care, and we heard a lot about the diagnostic odyssey patients experience today, even 20 years later. But I think over the last 20 years, there have been very positive progression. So today, as you heard, a larger number of approved therapies for use in patients with rare diseases. And newborn screening has significantly grown over the last 20 years. And I think we could clearly say that newborn screening is one of the major public health policy successes that we can point to, such that today multi-millions of people are screened around the world. And in the United States alone, I think we have up to 12,000 patients that are identified positively with a diagnosis that obviously lends to our ability to manage these patients much more acutely and much more quickly. And I think having a diagnosis also helps from a science perspective in how we think about looking at different approaches by which we can address these new indications, particularly if they're new. So from my perspective, I think they need still, despite 20 years later, a continued investment in expanding further our diagnosis and screening of these individuals, because of all the merits that we just talked about that can be gained from an early diagnosis, from a management perspective and also from a drug development perspective.
Thank you. That's true, because if we can diagnose early, then we can track that natural history and really understand what that natural history looks like and where and when we can intervene. Dr. Tierney, how many tests, how many newborn screening tests do you have available now in Massachusetts? And how, usually in our state of Ohio, there's 60 or so, and you have 8,000, 10,000 rare disease patients. So where are we now with screening in Massachusetts, and how are we going to get there?
So the Massachusetts newborn screening program was the first newborn screening program in the U.S., and we have constantly expanded. The first test was added in 1961, and since that time, we're now up over 60 tests. There's a federal panel called the RUSP, the Recommended Universal Screening Panel, and so states will try to align themselves with the RUSP with regards to the diseases that they'll test. In Massachusetts, we have a special approach where we'll look at diseases on the RUSP and then conduct pilot studies of new diseases to make sure that they're appropriate for Massachusetts. And so that process takes somewhere between 6 months to a couple of years to validate the new disease. But we've just recently added 3 diseases onto the Massachusetts panel through that pilot process. And in Massachusetts, the diseases that are on the newborn screening panel are required. So every baby born in the state is tested through that with that required disease, and then for the pilot studies, they can opt in to that.
So then what happens? So you've screened a baby, and you found that that baby has a rare disease. What happens next?
Well, I would say that this is a screen, so a blood spot is tested, there is a signal that's positive, and then there's a number of tests that are done to confirm that and make a diagnosis. So there's a difference between a positive screen and a diagnosis, and then so a positive screen will result in a notification to the parents and then a referral to a physician who can do the additional testing and then develop a care plan if that test is confirmed.
Great, thank you. And the handoff is to you, Dr. Irons?
Yeah, and I think the handoff, in Massachusetts, we've been really fortunate in Massachusetts because, as Dr. Tierney said, it was the first newborn screening program. We started with PKU and hypothyroidism, and those handoffs occurred over time. Those handoffs were solidified in terms of occurring over time. We've even developed on a national level, the American College of Medical Genetics has developed something called ACT sheets, which are on the public website, so that when a pediatrician gets a call from the newborn screening program, they can actually go and look at, this is what the condition is, this is what you have to do. But that follow-up is really important in terms of doing the handoff so that families aren't caught in the middle. Because as Dr. Tierney says, it really is a screen and there needs to be a confirmation that's done. And also treatment instituted for many of the conditions that have treatment. The one thing to remember as we think about expanding newborn screening, and I'm a proponent, I'm a pediatrician, the earlier you can identify a problem, the better. You cut the Diagnostic Odyssey short, you can institute testing, institute treatment if it's available, but you also have to know what to tell families. And so you have to have an understanding of what the condition is. And a lot of these conditions have been clinically defined by people who come with symptoms. So what happens a lot often, not all the time, when a new test is added to a newborn screening panel is that we start to see the mild or unaffected part of the spectrum of the disease, because every genetic disease has something called penetrance, where you either get symptoms or not. And so you have to know what to tell families about what that is. And I think the expanded newborn screening pilot studies that are being done that have been done over the last few years, I think are really important to get that data so that once the expansion occurs, we know what to tell families, we know who to send them to, and we can work with our colleagues who are developing innovative therapies to offer that.
But I think we can expand on that. I think we have to think about looking at new and emerging technologies, such as, I think we heard whole genome sequencing. I think there are several pilot programs that are ongoing right now, particularly in the NICU, to look at newborns initially, to look at whether how effective that whole approach is, as well as how appropriate and where we use it. So I think those are the initiatives that I think we look at that could allow us to expand the number of indications that we can actually identify. And there are a number of pilot programs ongoing right now. For us, Alexion, we're working with, for example, the Rady Children's Institute to look at the effectiveness and appropriateness, but we're also part of a larger consortium that's called Begin NGS that is comprised of a large number of biotech, as well as pharma companies, as well as stakeholders and technical experts to help advance the development of these emerging technologies. So the hope is that these could become another member of the armamentarium of tools that we can use in the diagnosis of patients.
So it becomes time matters for all of us who've seen or watched or loved someone with a rare disease. How do we get there from 60 with some pilot programs to whole genome sequencing? How do we scale? How do we get that in place, and how long do you think it'll take?
I just wanted to say that I think about it as there's directed testing with potential exome or whole genome sequencing for children, babies who are sick. They are in the NICU or they have a syndrome that's not diagnosed. So we can use that as a diagnostic tool. But then to think about newborn screening, that means that the entire population is going to receive a screening test. I think we're a little bit further out from using whole genome sequencing in that way. But there is a potential to do that with lots of ethical conundrums that would
Of
be
course.
wrapped into that.
Of course. How would you see that happening, Dr. Irons?
I just to segue from what Dr. Tierney said, he's absolutely right. So I think that, newborn screening is obviously screening, all newborns. And I think in terms of equity and access, it actually provides the most equity because you're screening the entire population. But what we have been doing for years is directed testing. Children come to geneticists, they come to neurologists, they come to other specialists with a set of symptoms, intellectual disability, autism, physical abnormalities. And over the years, we've been able to identify a clinical syndrome. These are conditions that have been clinically described over years that we have slowly chipped away at identifying what the underlying condition is. There's a syndrome named Smith-Lumley-Opitz syndrome that geneticists diagnosed for years. Probably about 20 years ago, I discovered the underlying defect that caused that. It took that long, to do that. I think whole genome sequencing and exome sequencing, the testing that's now available, is kind of a shortcut to diagnosis for about probably 50% of those kids. As Dr. Tierney said, we're using it a lot in the NICU and the PICU for severely ill children to help identify what their underlying diagnosis is. And we're using it increasingly in the outpatient setting when people come to us. 50% actually might not sound like a lot, but to me, it's a huge game changer. And it has really shifted the conversation from diagnosis alone to diagnosis and therapy. And I think that's really the exciting piece about this.
I really wish we could do that for 50% or more. I think that sometimes what we see in rare diseases is the rare disease is diagnosed, but there are other diseases there. And so what happens is you get a single rare disease, Duchenne or whatever, and then all of the other symptoms that this child exhibits are thrown into Duchenne, right? So how do we clarify what we're looking at? And do you think whole genome sequencing is going to enable us to do just that?
I think it can help. I think it really can help. The one thing, and you're absolutely right about what you just said about lumping everything into a diagnosis. And I think that one of the issues is many genetic conditions have this heterogeneity. So if you look at a condition that's clinically described, not everybody has everything. And so they're going to kind of come out into that spectrum of things. But what happens, and I use this as a cautionary tale to the people that I'm training in my program, is you have to be sure of the diagnosis before you make it. Because a lot of times people will, and this is one of the issues that comes up with new genomic and genetic testing, is sometimes variants are identified that have not been reported to be pathogenic or to cause a problem. Jumping to that diagnosis doesn't help anyone. It doesn't help the child, because if the child doesn't have that, then you're kind of making yourself feel better by doing it. But even worse is that you stop thinking about other things, which I think is where you're getting at here, is you immediately kind of shut down, and it's like, oh, there's a diagnosis there. But you have to be sure of the diagnosis, which is the variant interpretation piece of this. But you also have to have your mind open to not everything. If something doesn't go along with what you think the child has, or if there are other things, people can have two different things. It happens. Yeah.
What can industry do, Dr. Chen? How can you help us have 50% of these children? It's a big ask, right, for Alexion or others. But how can we get there?
Yeah. So as all we do in rare diseases, I think patients comes first as part of a culture of patient centricity. So that, having said that, I think finding the right diagnosis is an important first critical factor in terms of how we go about developing the right drug for the right patient. And if we have a view of the longitudinal progression of this disease, to administer the drug at the right time. So the benefits of the ability to diagnose and screen and identify these patients very early are manifold. I think one of which is, as I said earlier, the opportunity to have a very early view on the pathophysiology and the pathobiology associated with these new indications or diseases for which there is still a positive knowledge, because this allows us to focus our efforts from a research perspective on those aspects of the disease that are most relevant and most appropriate for that particular patient that we're trying to solve. As you mentioned, I think early diagnosis also provides us with an early view of the natural history of these patients that might allow us to then develop, for example, biomarkers as well as clinical outcome measures that will allow us to evaluate the relative merits of the different therapies that we might be looking at. And then early diagnosis, even when we have a therapy, obviously is very important because it allows us the opportunity to treat and intervene very, very early. And this is an important consideration for diseases that are very rapidly progressive, to prevent any presentation of irreversible damage that might occur in these individuals. Industry, we're also looking, I think someone mentioned AI, and in Alexion we're working with a company called Envision Medical that's looking at development of algorithms that will allow us to have a view by looking at the various echocardiograms, the propensity of patients at risk of developing, in this instance, TTR cardiomyopathy. So this is some of the things that we're doing in the industry to help with that effort. And of course, with that AI example, that could obviously be expanded to other indications as well.
Yeah, I think the application of AI, while a little bit terrifying on one hand, is really quite amazing in being able to apply those algorithms to diagnose. So Dr. Tierney, let's say we're 5 or 10 years into the future and we are able to do testing on 50% of these kids. Are the labs ready? And what I can imagine being a genetics lab and getting all of this data. How do they sort through it? What are they going to do? Are they prepared? Or are we prepared?
Well, I think that the state government of Massachusetts runs the newborn screening program. And so every disease that's added needs to have a pathway from screening positive to confirmatory testing to treatment. And so I think that there would have to be a large scale up in that capacity as new diseases come on. And I think that that's a significant, it's significant work. In terms of the testing, exome testing or whole genome sequencing for as a diagnostic tool for children that are sick, where that testing is done, I imagine it would be probably subcontracted. Probably would not be going through academic centers, and whether labs have the capacity, I think that I would be speculating, but I think that there's a lot of interest in those technologies, so I do imagine that it will expand.
Dr. Irons?
I think you're absolutely right. I think that the testing piece is probably the easiest thing to institute, as long as you have the funding to make sure that you're doing it appropriately. I think it's this handoff and educating the people that you're handing off to that is going to be really important. I also think that we're in this interesting window of time where it's really important for all pediatric specialists, geneticists, and others to really try to identify, to confirm the timeline of the condition. Because I think, to your point about looking at outcomes, we have to actually understand what the condition is and what that natural history of the condition is in order to evaluate our therapy, and also determine who we're going to treat and who we're not going to treat. So there's an educational component there that I think is really important, that we do when we're talking to other, the other specialties that go along with children, with the care of children. But there are only You know, we're the smallest subspecialty, we're the smallest specialty, medical genetics, and I think, you know, there are some states that don't even have a medical geneticist. We tend to aggregate to the coasts, but I think that in terms of looking at the entire country, that's a consideration also in terms of newborn screening, is who are you going to hand off this child to?
So we did some work. I spent 6 months in Mississippi, and my work down there was to understand the barriers to diagnosis, and I found 3 major barriers to diagnosis. One is the language used by the population that exists in Mississippi. It's a very southern population. There's about 10% Vietnamese population, and often in underserved states like Mississippi, there's a person on a J-1 visa. So there was a physician who was born and raised in India and was down in Mississippi, and a lovely southern grandma came and said, "My grandson waddles like a duck." So he looked at me and said, "What does that mean, right? And what do I do next?" So his concern was, as we discussed after this, the second barrier was his, and that is referral to a clinical geneticist was 18 months to 2 years. So does he refer based on the comment of waddle like a duck? What happens then? And the third barrier was the fact that there is very limited time in a very small exam room. And this child crawled on grandma's lap, and that looked quite normal. So the waddling piece and the crawling up on grandma's lap didn't resonate with that man at all. And so I think those are the barriers that how do we in this world, for people who are underserved, how do we, first of all, explain what feels like Star Wars testing? You're doing what to my where, and what's that going to mean? How do we explain that? How do we educate those primary care docs? And what about when there's only no or one clinical geneticist in the state? Who would like to fix that for me?
Maybe, sorry, just to say, consider generating apps. I mean, education is obviously the key component that's lacking here, right? But having some facile way that people can access, common databases that people can look up and assess and interpret some of the things that you mentioned, I think could be one thing that we could be working on as a collective.
I actually think if you look at, the 6,000 conditions that are out there, doing a 2-hour educational course in the, at midnight, when you're done with the work that you're doing, you're not going to remember it at the point of care. And I really do feel that we're at the point where a lot of this information has to be at the point of care. So when a pediatrician is seeing a patient with something, they can get the information that they need to know what to do with that patient, what test to send, or who to call. A lot of it is who to call, and I think pediatricians, and I may be biased here, actually do that really well, and they have the network of subspecialists that they call. But for people in states that don't have a geneticist, I actually think it's point of care testing, and that may be one of the benefits of moving to electronic health records, when you're able to go in and pull up some information, but that has to be developed.
Well, in electronic health records, Cerner and all have to talk to each other a little bit, which would be quite helpful. You were going to say?
I just wanted to add that we do have some tools now, like telehealth, that could allow providers to talk with specialists, but we'd have to expand access so that that conversation happen fluidly and people can be reimbursed for it. And we haven't quite figured out a model yet for that to happen, but I think that would be a relatively easy way to allow primary care doctors in rural settings or in under-resourced settings to have access to academic centers in Boston or other places where there is that knowledge. I think also multidisciplinary clinics where someone who has a child with a problem can be seen by a few different specialists, and they can put their heads together and think about, okay, this may be one genetic disorder or another, and then access to testing, right? Who gets access to exome testing, whole genome sequencing? Do insurance companies pay for that? I mean, I think those are all potentially concrete ways that we can get people shorten the Diagnostic Odyssey.
Yes, I would really love models where in telehealth there would be a group of physicians that in Mississippi or Alabama or some of those states could reach into a group of clinical geneticists and present the patient and at least have a direction to go in. I think that would be quite incredible. We have only a few minutes left, so I'd love each of you to say, what is the one thing you would like to see done to really expand newborn screening and the handoff and really promote equity so that children are diagnosed appropriately, the right diagnosis, and put in the arms of the people who can help? I'll start with you, Dr. Irons.
God, there's a lot I'd love to see. But what I would say is that we really, and we have a window in time to do this, is to create that handoff system from an operational standpoint, to create the infrastructure for the handoff. You know, whether that's in children's hospitals or whether that's in different, multidisciplinary centers, there has to be an identified person, there has to be a process, and we have to have that in place before we expand from what we have now to the several hundred. And there's time.
I think from my perspective, I think clearly we're very excited with the opportunity of whole genome sequencing. But for me, and again, from a scientist's perspective, I think it could warrant from a great investment in new tools that are more high throughput in terms of what they can do. And that could be scale. That's what I'll be looking for. I think there are some developments that are in place besides whole genome sequencing, but that's what I would think would be something that we need that could clearly catalyze this challenge that we're facing today.
Thank you.
Yeah, and I think that Massachusetts is unique in that we have a very strong life sciences industry and a very strong academic medicine in Boston, but in rural areas there is not as much access. And so I would be interested in finding ways for people who are living outside of Metro Boston to be able to access the resources that we have here, even within Metro Boston, who may not have those resources. And so whether that's through expanding access through telehealth to specialists, to lower barriers to specialty providers by making sure that people can go out of network, I think those would be two ways to get people to the care that they need more quickly.
Thank you. I do think of Boston as a superpower in medicine. I have to say we're all jealous when we live. I'm from Ohio, and we're all jealous to look at Boston and its capability. And I, in my delusions of grandeur, think of building bridges so that we could either use telemedicine or bring these people here for a complete evaluation, knowing that we'd quite oversize in terms of the number of diseases. But you are lucky here, and I think to build with you, and certainly with the advocacy organizations, we are lucky enough because we have a package before the RUSP. We've been to Ohio, Minnesota, New York, and we have newborn screening on their panel. So in advocacy, and I think in the last panel this was discussed about collaborating with medicine and industry and advocacy, because I think together we could bring genome-wide association testing to babies that are born. We could educate the families about what that means, and we could see a time when children are diagnosed and treated and put into the hands of people who can adequately care for them. I thank you for this panel. You are terrific. I'm going to move to Boston tomorrow. But thank you so very much.